How's it going, guys? It is 3:04 a.m., 24th of April. Here in Japan, we have a pass level question for Neuro Step 1 Internal Medicine 2CK. Before we get started, please subscribe to my channel. Really appreciate it. Give it a like. Really appreciate it. Find me on Instagram, mehlman_medical, mehlman_medical, links down below. Find me on Telegram, links to Telegram group and channel down below. Now start the clip. 33-year-old woman burned her hands in the kitchen on several occasions over the past 6 months. Examination shows mild atrophy of the arms and hands, decreased pain, temperature sensation in the C5T1 dermatomes, touches preserved. Question wants to know which of the following most likely explanation for these findings. Let's just hop to the answer choice here. Choice A, anterior horn destruction. Wrong fucking answer. Anterior horns, part of the corticospinal tract, which is motor function, which has nothing to do with this. Okay, now atrophy of the arms and hands, I'll talk about as we move through the question, okay? But anterior horn destruction, this is going to be two things on USMLE. Polio, okay, poliomyelitis, and it's going to be slightly lower yield, but it's asked on PEDS 2CK, which is Worden-Kaufman syndrome, spinal muscular atrophy, where you can get tongue fasciculations, okay? But corticospinal tract runs from the upper motor neuron, runs from the cerebral cortex anterior to the central sulcus down to the anterior horn, that's UMN. Lower motor neuron, anterior horn down to the muscle itself, LMN. So UMN findings will give you hyperreflexia, okay, so brisk reflexes, Babinski sign, clonus, okay, hypertonia, whereas LMN findings will give you fasciculations, atrophy, hypotonia, diminished reflexes. Wrong fucking answer. Choices B and C, fasciculi cuneati gracili. Wrong fucking answers. Okay, so these are the dorsal columns. So the fasciculi cuneati are lateral, bilaterally, within the dorsal columns and carry vibration proprioception from the arms up to the medulla. The fasciculi gracili run medially, bilaterally, within the dorsal columns and carry vibration proprioception from the lower limbs to the medulla, okay, the nuclei respectively for the cuneati gracili. So the dorsal columns can be affected classically tabes dorsalis, okay, neurosyphilis, where you need to know it can occur in younger patients as well. There's an 18-year-old on one of the 2CK neuroforms, so it can occur in any age. And what they love doing is giving you a positive Romberg sign, which is where a patient closes his or her eyes and loses balance. So for example, if a patient has ataxia and you want to determine the etiology of the ataxia, is it the cerebellum, is it the dorsal columns, then you have him or her do the Romberg test. If it's a positive Romberg sign, he or she loses balance with the eyes closed. That means the dorsal columns are fucked up, usually, okay, for USMLE. Romberg sign is negative in contrast, where a patient doesn't lose balance with the eyes closed. That's going to be cerebellar ataxia, usually, okay? For instance, alcoholics on USMLE. Other things we can talk about, okay? Of course, dorsal columns can be affected, B12 deficiency, the neurologic problems due to B12 deficiency called subacute combined degeneration. So you can just remember spinal thalamic tracts not involved. You're just going to have the dorsal columns, corticospinal tracts, spinocerebellar tracts. Point is, wrong fucking answers. Choice D, lesion at anterior white commissure, correct answer. So diagnosis here, Syringomyelia. Anterior white commissure is the decussation, the crossover point for the spinal thalamic tracts within the spinal cord. Pain and temperature sensation, okay? So you need to, this is pass level as I said. So you can have a syrinx, which is going to be CSF accumulation within the spinal cord itself, and for whatever fucking reason likes to occur at the anterior white commissure. And as I just said, since that's the decussation point for the spinal thalamic tract, bilateral loss of pain and temperature, okay? So you say, well, what about the mild atrophy of the arms and hands? Sometimes that can be seen, okay? Like sometimes you can have impingement on adjacent tracts. Sometimes you can have involvement of anterior corticospinal tract, lateral corticospinal tract. Sometimes you can get other miscellaneous findings in the vignette. But what the vignette will give you, 5 out of 6 questions for Syringomyelia is bilateral loss of pain and temperature. There's one question on one of the 2CK forms where they don't mention pain and temperature loss. Okay, every student says, what the fuck? It's a 280 level question, but you're able to eliminate to get there. All right, so Real quick, myoneural junction disorder, wrong fucking answer. USMLE likes this answer choice to refer broadly to myasthenia gravis, Lambert-Eaton syndrome. Okay, myasthenia gravis, antibodies against postsynaptic nicotinic acetylcholine receptors can be a paraneoplastic syndrome of thymoma, diplopia, dysphagia, ptosis. Triad gets worse with activity, whereas Lambert-Eaton syndrome is going to be antibodies against presynaptic voltage-gated calcium channels, can be a paraneoplastic of small cell bronchogenic carcinoma, improves with physical activity. In this case, wrong fucking answer. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.